Hello? It's okay? All right. Welcome, everyone. Thank you for joining us. I was going to say this afternoon, but it's still morning. We're here presenting on the panel, Making It Personal, using motivational interviewing to increase vaccine uptake across 4 countries. So we have a wealth of experience on our panel today, and I'll start by making some introductions. Okay, wonderful. So we have presenters here who will be talking about their experiences in Romania, Australia, Canada, the US, and Kenya. To begin, we have Dr. Arnaud Gagneur, who's an associate professor at University of Sherbrooke, where he focuses on implementation and evaluation of the Quebec Plan for Promotion of Vaccination. He's particularly focused on validating a new concept for the promotion of vaccination through an educational intervention in maternity based on the techniques of motivational interviewing. Next up, we have Dr. Julie Leask, who's a social scientist and professor in the School of Public Health and Faculty of Medicine and Health at University of Sydney. She co-leads the Social and Behavioral Insights Research Group, and her research focuses on social and behavioral aspects of vaccination and prevention of infectious diseases. Next up, we have Hinda Omar, who's a nurse and educator specialist, joining us from the Minnesota Department of Health in the US. And there she focuses on various community public health programs and is actively engaged in childhood vaccination health promotion with the Somali population in Minnesota. Next up, we have Raluca Zaharia, who is a Communication for Development, or C4D officer at UNICEF in Romania, where she coordinates behavior change and social mobilization campaigns and interventions. And she works in partnerships with the child protection, education, and health departments. And then myself, I'll be moderating. I'm Dr. Nessa, a social epidemiologist, implementation scientist, and fellow at the U.S. Centers for Disease Control and Prevention, where I work on the demand for immunization team. And I focus on examining and addressing the drivers of vaccination demand and uptake. And I have a particular focus on mainstreaming gender in immunization and looking at implementation and scale-up of evidence-based interventions to address gender barriers related to immunization. Okay. We happen to think this is going to be the most fun session that you've attended at the conference, and I'm very unbiased when I say that, because we're really wanting you to take away some tangible skills in motivational interviewing. So this is going to be a broad introduction to MI techniques in immunization, but you're going to get the chance to apply some of what you'll be learning through a role play, and we'll be sharing resources that you can take with you to think about how you can use this in your own practice and research. So we've done our introductions. We'll start with an overview of key MI concepts and a short video example. Then we'll move on to the 4 case studies across the different countries that we work in, all focused on using MI techniques to have vaccine conversations. We'll have a brief question and answer session and then move into our breakout groups to apply what we've learned through role playing and getting a chance to use the MI techniques. And then we'll come together and debrief and finish up the session today. Great. So now I will be handing over to Arnaud.
So good morning, everyone. I'm very happy to be here. So before speaking a long time about motivational interviewing, maybe it will be interesting to know what it is and to try to demystify what is a motivational interviewing. So I will make a brief introduction to explain what is motivational interviewing and how we could use motivational interviewing for vaccine-hesitant patients. So just before that, I will ask you to think in your mind, take two or three seconds to if you meet someone who say you there's nothing reassuring about what I have read on the internet, it's not that I'm against it, it's that there is some point. The fact is the vaccine is developed too quickly, and I don't quite trust it. So what you spontaneously reply to this person, what is the first sentence that comes into your mind to say to these people? And we will see at the end of this panel discussion if you will have the same first sentence for these people. And just before starting to show you lots of scientific data to prove the effectiveness of motivational interviewing, I want also to share with you a personal experience, a story about an hesitant person and the motivational interviewing approach. You could find this testimony in the link at the back of the slide. It was an interview of Marie-Hélène by a journalist of the Boston Globe. And Marie-Hélène was a mother who had a premature infant in my unit. It is Toby, and on the photo you could see Toby and his mother. And Marie-Hélène was an anti-vax mother. And Toby was the fifth child of Marie-Hélène. And during all the 5 months hospitalization of Toby in the neonatal unit, she didn't want him to receive any vaccine. And the day before discharge at home, the nurse on my unit called me and said, Arnaud, could you speak with Toby's mother about immunization because Toby didn't receive any vaccine? So I spent 45 minutes. I should admit that it was 45-minute discussion with this mother using a motivational interviewing approach. And at the end of this intervention, I said thank you to the mother to have the openness to discuss with me to immunization. And I said her, think about that, and I will respect your decision. And the day after, in the morning, my colleague in charge of the units called me and said, what did you say to this mother yesterday? Because we give all the vaccine to Toby this morning, so what's happened? And the story is more powerful because Marie-Hélène come back to home and she organized the vaccination of the 4 old children at home. And 1 month later, I received in my consultation a friend of Marie-Hélène, an anti-vax mother who had 3 other children, not vaccinated children. And after 1 hour of consultation, she organized all the vaccination of the 3 children. So what's happened with this kind of approach using motivational interviewing, and we will see how we will do that. So first, I will take a few minutes to explain what I call the information paradox. Because maybe you have experienced that, but with some hesitant people, to give more information, more facts, try to educate people didn't change anything, and worse, it could be ineffective and backfire and reinforce vaccine hesitancy. But on the other hand, when you ask parents and people, what do you need about communication about vaccination? The answer is, we want more information. So what's wrong? Give information doesn't work, and you ask people, what do you need? We want information. So there is a problem. And probably the problem is the way to give information. And the challenge is how to give information that makes sense for the people, how to give information that are relevant to the people, and how to give information in a way that it is not a fight with the people. And we will see how a motivational interviewing approach could meet the needs of the people of what information is important and how to give this information for these people to motivate to receive the vaccine. So the bad news, it is that there is no single magic intervention, and we should adapt to every people. Each people has his own reason for hesitate to receive a vaccine, has his own cultural aspect. So we should adapt our intervention to reach the specific needs of each people. Motivational interviewing was first developed by psychologists Miller and Wolnick 30 years ago. At the beginning, they developed this approach for people suffer from toxicomania, alcoholism, and they saw that if you tell to these people, you should not take drugs, it's bad, it's not good for you, it doesn't work. But if you are in a partnership, in a judgmental approach, and you try to increase the own motivation of the people to change himself and to use the own strengths of the people to change himself, it works very well. So we adapt this principle of motivational interviewing to hesitant people and to find themselves their own reason to motivate to receive a vaccine. And in motivational interviewing, we use 5 skills that we're going to see what they are after. It is of open-ended question. We use affirmation or valorization, some reflective listening, some summaries, and also a way to give information that is elicit, share, and elicit, and we will have example during this panel discussion. So now we're going to see an example of an interaction between an immunization counselor with hesitant parent. It is a real situation. They are real hesitant parents. It is Loic's parents. They doesn't want to vaccinate him before the age of 2 years. And we're going to see the first 3 minutes of interaction with the counselor. So we will start the video now.
Oh, bonjour maman. Bonjour papa,
Bonjour.
Merci beaucoup de m'accueillir. Donc, je suis Arnaud, donc je suis conseiller en vaccination. Puis mon rôle, un petit peu là, c'est d'avoir une discussion sur la vaccination avec vous, puis de répondre à vos questions. Je suis avant tout là pour répondre à vos questions. Et donc, je vais commencer par une première question. D'ailleurs, vous en pensez quoi de la vaccination? Est-ce que vous avez envisagé la vaccination de Loïc? C'est quoi votre position par rapport à la vaccination?
Ben oui, j'ai envisagé la vaccination. Je trouve que la vaccination se fait trop jeune.
Ouais.
Mais sinon, je viens de faire vacciner mon fils de 2 ans.
D'accord. Ok.
C'est ça.
D'accord. Donc, ce que je comprends là, c'est ça, que vous pensez que la vaccination, c'est important,
Ouais.
mais peut-être une crainte par rapport à quel âge on fait la vaccination. Ouais. Est-ce qu'il faut vraiment faire la vaccination à cet âge-là ou à quel âge on doit la faire? D'accord. On pourra l'aborder si vous voulez. Hein, c'est bien important. Donc, vous avez envisagé de vacciner Loïc, mais un peu plus tard, si je comprends bien. C'est ça. Bon. Parfait. Est-ce que dans la vaccination, vous avez certaines questions par rapport à c'est quoi la maladie contre lesquelles on protège? C'est quoi les vaccins qu'on donne? Est-ce que vous avez des questions spécifiques un petit peu?
Ben, les vaccins en soi ne me dérangent pas. Ouais. C'est vraiment l'âge à laquelle on les donne.
D'accord. Donc c'est vraiment...
Parce que je les ai toutes données à... je viens juste de les faire. C'est vraiment...
D'accord.
Okay. Ça fait 1 mois que je les ai faites. Là,
OK.
C'est une question aussi d'anticorps que quand il est jeune, les anticorps ne sont pas tous développés.
D'accord.
C'est une crainte nous autres on a.
Ouais.
OK, parfait.
J'envoie pas mes enfants en garderie.
Ouais.
Qui restent pas mal chez nous.
Ouais.
Puis j'allaite jusqu'à 18 mois.
D'accord.
Fait que tu sais...
OK, donc à ce moment-là, vous pensez qu'ils sont moins susceptibles d'avoir des maladies, parce que comme ils sont à la maison, puis vous allaitez, ça les protège aussi, c'est ça?
Oui.
D'accord. Donc c'est vrai que vous avez raison, parce que le mode de vie, l'exposition aux maladies change en fonction du mode de vie aussi, bien sûr. C'est vrai que la garderie les explose à beaucoup plus de maladies. Et puis l'allaitement, on sait que ça protège aussi, et ça donne des anticorps de la maman aussi au bébé. Donc tout ça, c'est des bonnes stratégies pour protéger le bébé. Donc à ce moment-là, est-ce que ça vous intéresse un petit peu qu'on parle un petit peu, parce que vous parlez d'anticorps, de voir un peu comment ça fonctionne un vaccin, comment ça fonctionne l'immunité, comment ça fonctionne un vaccin. Ouais. On va peut-être commencer par ça, puis comme ça on verra un petit peu pourquoi on vaccine. Alors qu'est-ce que vous avez compris du fonctionnement d'un vaccin? Qu'est-ce que vous papa me parler d'anticorps? Qu'est-ce que vous avez compris un peu de...
Moi, je pense qu'il injecte les médicaments sans le noyau. Pas le médicament, la bactérie sans le noyau.
Ouais.
Puis là, ton corps crée des anticorps face à...
Ouais. C'est bien. Ouais.
C'est ça que j'ai compris.
Ouais, c'est ça. Est-ce que vous connaissez le terme d'antigène? Moi. D'accord. Okay, so you have just
see the 3 first minutes of an intervention. So I will present how the summary of what is a motivational interviewing approach intervention with a hesitant parent. So as you have seen in the video, the first step of the intervention is really, really important. And the main goal, and I could say the only goal of this part of the intervention, is to establish a trustful relationship with the people. If you are not succeed to establish this trustful relationship, you will not be able to give any information or to change anything for these people. So the first aim that you have starting your intervention is to establish a relationship of trust. You use the IMI spirit. What is IMI spirit? Is to be not judgmental, to accept the hesitation of the people, and to be curious about their belief, their position, what did they know about immunization and why they are hesitant. At this step, it is really, really important not trying to correct any misinformation at first. And you have seen this example when the mother starting speaking about breastfeeding, put the child in daycare center, etc. I didn't say, yes, it's good, but it's not enough. I said, yes, it's good strategy. And when the father say, the antibodies are not mature, there is not enough antibodies, etc., I didn't try to correct any misinformation in this specific step of the intervention. We should not try to convince with more arguments at this step of intervention. So this step of intervention is to let people express their fears, their concern, and we show empathy. That is showing to people that we want to understand and we want to help them, and we don't want to change something or to obtain something for the people. And the empathy, it is the most effective way to move toward a change. So the first step of the intervention is to establish a trustful relationship and to also trying to understand what are the specific determinants of the person hesitation. And so we use motivational interviewing skills as open-ended question to let people express what are their concerns. We use also complex reflect, that it is to show to people that we have understand what they want to say or what are the feeling. For example, in the video, when the mother express that she breast her baby, she don't put in care center. My complex reflex was to say, okay, so with those strategy, you are trying to protect him. And so she said, yes, I want to protect him using those strategy. And also, in this second step of intervention, we will think about what will be the relevant information that we will provide to this person to increase their perception of the importance of vaccination. So when we able to determine what is the specific determinant of hesitation of the people, we could choose what could be the good information to give to the people and not to follow a list of information that doesn't make sense for the people. And after that, in the third phase, and only in the third phase, we could start to share information using the ask, offer, ask tool, that it is to always ask permission before to give information, and also to try to arouse the curiosity of the people, and also to try to co-build a new knowledge in partnership with these people to increase the perception of the importance of vaccination, because the information that you will give to these people should make sense for these people. So if we want the people to change his mind about immunization, it should make sense for the people. So you have to choose which information will make sense for these people to change his mind about immunization. And the last step of intervention is to respect all the time the autonomy of the people. and to let the people take their own decision. And it seems to be counterintuitive to obtain some good results, to let people make their own decision. But it's a really, really powerful tool in motivational interviewing to let people their autonomy for their own decision. So I will, okay. So now after this introduction, we will present 4 examples of studies that we are doing across the world, and we will present the first study in Canada, and it is the promotion strategy that we have developed in Quebec, in Canada, using a motivational interviewing approach in maternity wards. And so we have trained some healthcare workers in motivational interviewing in immunization, and they are meeting every parent at birth for an educational session. And I will show you the results of this intervention. So what is a PromoVac strategy? It was based off the need of an early strategy of promoting of vaccination to avoid any delay in the first vaccine. That lots of studies have shown that if the baby receives late the first vaccine at 2 months, there is a lot of chance that all the childhood schedules of vaccination will be delayed. So it is really important to have a very early promotion strategy. And the first idea of the PromoVac strategy was to meet every parent at the birth of the child in maternity wards, because we could have a systematic impact of an intervention in maternity wards where all the births occurred in Quebec. And the second idea was, as we have observed a failure of every traditional educational information strategy, we will integrate in this educational intervention a motivational interviewing approach, adapt to vaccine hesitation, and adapt to immunization. So the PromoVac strategy is to provide to parents an educational intervention at birth using a motivational interviewing approach in order to increase vaccine acceptance and hopefully vaccine coverage in Quebec. So we conducted a first regional cohort study on more than 1,000 families in the Eastern Township in Quebec. And we used a questionnaire with the parental vaccination intention. And what we have seen, after the intervention, we have observed a 15% increase of the proportion of parents who have a strong intention to vaccinate the child. And a lot of studies have proven the link of the vaccine intention and vaccine coverage. So we were very confident that it will be succeed to increase vaccine coverage. But we follow this cohort of infants compared to a cohort of infants born in the same maternity in the same period, and we follow the vaccine schedules for these 2 cohorts, and we're able to demonstrate a significant increase on vaccine coverage at each age of vaccination at 2, 4, 6, 1 year, and 2 years. And using logistic regression, we're able to demonstrate that if parents receive the educational intervention in maternity wards, the infants had 9% more chance to receive a complete vaccination schedules without any delay in the 0 to 2 years period. So after that, we conducted a provincial randomized controlled trial in the 4 main maternity wards in Quebec. And we obtained same results with, in each maternity, depending to cultural aspect, to language we use in French speaking mother and also to English speaking mother, according to socioeconomic level, according to ethnicity. We have all same impact of increase on parental vaccination intention with a global increase of 12%. And we have also used the vaccine hesitancy score developed by Douglas Oppel in the US. And after the intervention, we're able to demonstrate that this vaccine hesitancy score decreased by 40% in parents. It was also interesting to see that this score of hesitation could classify the level of hesitation of parents, and a score of more than 50 is strongly associated with a high level of hesitation. And on the diagram of the left, you could see in the box, the red box, that before the intervention, we have 16% of parents who had a high level of hesitancy with a high score of more than 50. After the intervention, we have only 5% of parents with this high level of hesitancy. So the intervention has a big impact also with parents with high level of hesitancy. So according to these promising results, the Ministry of Health in Quebec decided to implement the Promovac strategy into a provincial public health program. That is the EMI program. EMI, it's a French acronym for Entretien motivationnel en maternité pour l'immunisation des enfants. So motivational interviewing in maternity wards for immunization of children. And the aim of this program is to offer to all parents during the stay in maternity wards an open exchange on vaccination to support them in their own decision for vaccination of the child, and of course in order to offer the best protection for the child and while increasing the immunization coverage for all children in Quebec. So we evaluate this program, and we have observed same results that we have observed in the Promovac strategy studies. We have a huge impact on vaccine intention. We have also a huge impact on parental vaccine hesitancy score, and a very huge impact also on parents with a high level of hesitancy. So this study was made of a randomized sample of more than 6,000 of parents. We have also followed the vaccine coverage in Quebec using the Immunization Provincial Registry. And so we have followed the vaccine coverage in infants whose parents received the EMI program, compare in the same region in Quebec with infants that parents didn't receive the program. And so we observe a very significant increase on vaccine coverage at each age of vaccination, and the relative risk using the EMI program at 24 months is 1.10. So when parents receive the EMI program in maternity wards, the infants have 10% more chance to have a complete vaccine schedules with any delay during the 0 to 2 years period. So it was, according to the Ministry of Health, it was one of the most effective vaccination promotion intervention. So the program is now keep going on in Quebec in every maternity wards, and it was implemented everywhere in Quebec, and it's still found for several years now. So according to the training of the immunization counselor, so immunization counselors were trained in motivational interviewing in immunization and also in immunization knowledge. And we have developed tools for evaluate the acquisition of knowledge and skills and competency to use motivational interviewing in the immunization domain. It is a MISE questionnaire. And we have evaluate, so the motivational interviewing knowledge, the competency to use the skills, and also the self-confidence to use motivational interviewing in the vaccination counselor before the training, after the training, and we have also used this questionnaire 6 months after to receive the training. And what we have observed, it is a significant increase in motivational interviewing knowledge, skills, and self-confidence after the training, of course, but also 6 months after the training, showing that if people practice every day the motivational interviewing, they increase their knowledge and skills of motivational interviewing simply by practicing motivational interviewing. So for this program, we also evaluate the satisfaction of the parents. And as you could see, each item of satisfaction was more than 91% of satisfaction. So to appreciate, to participate in the program, to recommend, to offer this intervention to other parents. And one very important point that 97% of parents answer that the discussion respects their point of view about immunization according to the use of a motivational interviewing respectful approach. And also what is important, because at the beginning of the program, lots of healthcare workers said that maternity wards may be not the good place to implement this program because mothers are tired, the duration of hospitalization is very short, so it's very difficult to implement, etc. But when you ask parents, it is a good time for you to receive the intervention. Parents said yes by 93% of them. So, and we have a very high level of satisfaction of parents, and this program was really well implemented everywhere in Quebec now. So just briefly, we have used also a motivational interviewing approach in the context of COVID, and if you want, you could see in the New York Times, we have published a chatbot of an example of using motivational interviewing with people hesitant to receive a COVID-19 vaccine. We have also developed, in the context of COVID in Canada, the MicoVac program, that it is to offer to every people in Canada hesitant to receive any COVID-19 vaccine the possibility to have a discussion with a vaccination counselor by a Zoom platform. And we have good results with this evaluation of this study. We have also tested the Promovac strategy in France, in Marseille, and we have a huge impact on vaccine hesitancy in parents in maternity wards in the context of mandatory vaccine in France. And we have also used this motivational interviewing approach for marginalized population in France, so people living in the street, some immigrant population, with the training of health mediators to motivational interviewing and immunization. So they meet people in the street, and we have observed a huge impact on increase of vaccine intention of COVID-19 and also to receive a booster dose of COVID-19, a booster dose of DTP. So we have developed, and we finish, Nessa, I promise, a training motivational interviewing and immunization to specifically adapt motivational interviewing to the specificities of vaccine hesitancy. It is a 2-day face-to-face training course for healthcare professionals. We have also validated a tool for acquisition of knowledge and skill to practice email in the context of vaccination. It is a MyZ. And we have used this training for healthcare professionals in several contexts. So for a vaccination counselor in Quebec, for nurses involved in vaccination in Quebec, healthcare professionals in Romania, and Raluca will speak about that. And we have also integrated this training of motivational interviewing and immunization in the curriculum for family medicine resident in the Faculty of Medicine in France. And we have now in the currently developed e-learning course of motivational interviewing in immunization. It will be a 5 hours e-learning course with a certification. It will be available in French and in English, and it will be available in December this year on the Center of Health Expertise in Sherbrooke. And I put you the link if you want to see that at the end of the year. So just now, to think about this sentence, so will you spontaneously reprise the same first sentence that you have at the beginning of this panel discussion? So thank you so much, and I let the next speaker.
Thank you, Arnaud. And as you'll see, we were getting inspired about motivational interviewing around the same time. So I will be presenting an approach to motivational interviewing that we used in Australia. And it's called Sharing Knowledge About Immunization. And it involved many people, as these exercises do. Margie is here. She was very involved throughout the project, many others, so I want to acknowledge the work, the hard work of many people and the great ideas of a wonderful team in doing this work. So back in 2012, a bunch of us got together and we proposed a bit of a framework for healthcare workers in having conversations with hesitant parents in primary care settings in Australia, but with a view to something that could be used in any country. And the vaccine communication framework, which we published, was a structured process around identifying where people are at with vaccination, establishing flexible goals, tailored strategies, and focusing on a guiding style for people with ambivalence. Now, Arnaud's already given you a sense of what a guiding style looks like. But I think this classification is very helpful for healthcare workers. In healthcare, we choose any number of different ways of communicating depending on the situation, the relationship we have with the patient, the context, and the medical need. So one of the legitimate models is the following style, where you give people the information and they make their own choice. At the other end of that spectrum is the directing style, which is informed by paternalism, which is where we might say you really should get the vaccine or you really need this blood transfusion. So sometimes a directing style can be appropriate, even with vaccination, depending on the context. But with hesitancy, as you've seen from what Arnaud's talked about, guiding styles are more appropriate. There is a good way to go with vaccination. It's evidence-based. You can't just follow people. And a lot of health professionals do that. So that might look like, I'd like to see you get the vaccine, but let's work through your options, right? There's the respect for autonomy. So SKAI, what we ended up developing when we wanted to turn VCF into a tangible package, is informed by vaccination science, of course, communication science, and motivational interviewing. And what we started with was this spectrum of positions on vaccination. Note that the language will change as I show you what we ended up with. So you have the unquestioning acceptor, the cautious acceptor, the hesitant, the late or selective, and the refuser. We're labelling people. We're not labelling positions. So we changed that because people change over time and not necessarily stepwise. So our aims in developing this tangible package that we later called SKAI was to turn the VCF into something that clinicians could actually use, to integrate evidence, experience, and caregiver needs, and to reduce and prevent hesitancy. There's nothing wrong with being hesitant, that's normal, but if it ends up with vaccine refusal, that's a problem. And the setting was Sydney and Melbourne, Australia, between 2013 and 2018. There's a lot of detail here, I'm not going to belabor it. There's some pics of the team there, developing the resources, putting the concepts together. On the right there in the middle, you see Dr. Paul Kinnersley from Cardiff. He was on the team and worked with Stephen Rolnick, who was one of the originators of motivational interviewing. And he was responsible for bringing a lot of the motivational interviewing into what we ended up with. And we simulated conversations with parent actors in that picture you see on the right. So we had an extensive development phase which included workshops, stakeholder feedback, audits of what's already available for hesitant parents, in-depth interviews with providers, focus groups with parents to test out the prototype resources, stakeholder consultations to test out the whole system and look at how it could be integrated into primary care in Australia, and simulations of the scenarios to look at whether they worked, and analysing conversations between actual clinicians and actual hesitant parents, using where those conversations were recorded with their permission. And then phase 2 was the feasibility and pilot, where we developed the digital platforms for the tangible package and the training, and we piloted the integration into clinics, looked at how the package was used and tweaked it when we saw that certain things weren't working. So we took this real designer thinking to the package. It's been rolled out since 2019 by the National Centre for Immunisation Research and Surveillance. So that's the sort of the sustainability element of it. You need a body who will keep maintaining the information and promoting it with clinicians and evaluating it and improving it as you go. So the results of all that research showed that there was a gap in tailored high-quality information. Providers found vaccine refusal very difficult. And we learned that one of the most important things for a provider when a parent doesn't want to vaccinate or is really questioning it is to sit with the feelings that you have when that happens and recognise them. And that's the first step in being able to manage that difficult interaction, is just to, go into system 2 and look at how you're reacting, because then you're more able to respond in that more measured, careful, empathic way. Parents wanted to know what to expect after vaccination, along with all the other stuff that they want to know before they vaccinate. So that informed the consent resources. And vaccine refusing parents, we knew from other research, experienced conflict in healthcare and stigmatisation in everyday life, in their social lives. Risk information, which we tested with parents pre-post, didn't increase their hesitancy, right? So we wanted to do a non-harm study to make sure that the risk information we had in the consent resources didn't make them worry more about vaccination, because we wanted to inform them about side effects. Providers sometimes missed opportunities to recommend vaccinations, so there was a lot of following and not enough guiding. And we came up with a final set of pathways. And this is a schematic that depicts what it looks like. So it's much more simple. People may be ready, they may experience hesitancy, or they may plan to decline vaccination. You've got to know where they're at in primary care. You can't treat everybody as if they're hesitant. So that's why asking questions and having a way to elicit questions and concerns, even from what parents might write down on a piece of paper in the waiting room, can help save time in that time-pressured clinical environment. And then the resources themselves for parents are tailored to their position. So consent resources for those who are ready to vaccinate, questions, answering common questions, resources for those who are worried, a resource to help parents weigh up the risks and benefits of vaccinating, to respect their autonomy, and it's based on decision aids. And then for declining parents, a tool that says, okay, I understand after we've had this discussion that you plan to not vaccinate. I'd like to offer this resource for you, which is a what to look out for. Not what to look out for if your child isn't vaccinated, because kids can still get vaccine-preventable diseases even if they're vaccinated, but simply a what to look out for resource. And the goal there is to maintain trust. So I'm not going to go through the strategies there because they're very similar to what Arnaud's been talking about. But I want to take you through some examples from actual clinicians where we tried to draw out these vignettes from their good conversations with parents to give as examples in the training. So an example of eliciting questions and concerns would be, so I understand you've had some concerns about getting little Florence vaccinated. An example of summarising was when the clinician said, so if it's okay with you, I'd like to summarise what you're concerned about, you're concerned about what's in the vaccines, particularly the preservatives, but also the mercury and fluoride, right? And when you hear fluoride, you think, oh, I've got to correct that straight away because there's no fluoride in vaccines. That's resisting the writing reflex, that reflexive desire to write wrong thinking. Agenda setting, you can see the example there. Evoking, recognising and reinforcing change talk. So this is a rare example. We didn't see a lot of it, which is why we emphasised it in the training. Are there any particular diseases that you're concerned about her getting of the vaccine preventable diseases? And recommending vaccination. The evidence was showing that even when people are hesitant, it's important they know that you think their child should be vaccinated or they should be vaccinated. So we say that the timing and tone will differ, but a recommendation to vaccinate is important. I might skip through that. So just to quickly show you the package, we have a website for providers which gives the tip sheets for having conversations with parents who are vaccinating, who have questions, who are planning to decline vaccination, and it takes them to those resources to give to parents. We have a parent website which we tested with parents. We got them to show us how they'd use it and complete certain tasks. You see a tab there that's I am vaccinating and another that says I have questions. And that I have questions ones has the resources for the parents who are planning to not vaccinate. But we didn't want to feature non-vaccination as a major option because we didn't want to socially norm it. This is an example of the resource for clinicians, which is when you're talking with parents who have questions, it reminds them of the goals that they would have learned about through the online training that they would have done. The presentation, so how that parent or caregiver might present, and then the recommendations for the conversation with little examples there, some of them adapted from the actual conversations we recorded. SKAI has a mobile version, and there are also handout cards with QR codes for parents to take away. We've done lots of training around this face-to-face. This is a workshop with nurses. I'm a former nurse and a midwife, so it's been delightful to work with nurses in this area. And they're role-playing conversations after learning about the practices. And there's the online training there on the right. SKAI has been adapted, so Margie and team adapted it into the Mum Bub Vax pregnancy vaccination resources. And it's a little bit of a different looking package, but it all sits there on that website, which is skai.org.au. The National Centre for Immunisation Research have continued to adapt new resources, including these ones that are tailored for Indigenous communities that have the involvement of Indigenous people in writing them. And we've, of course, because we're much more in adult vaccination with COVID and wanting to see people have COVID boosters and flu vaccines and so forth, they have adapted the resources for adult vaccination as well. So, vaccine communication tips are welcomed by health professionals. They don't want to be told how to communicate because in primary care they have those skills, but they do like the tips. SKAI blends motivational interviewing, but it does it through this pathways approach, so it's a little bit different. But it's designed to be sort of integrated into routine care and scaled up. Identifying a person's position on vaccination is central to the approach, that communication pathways approach. And the principle is you ask more than you tell in the conversation, if it could be boiled down to the most simple of practices. And recommend vaccination to all people. Obviously, your timing and tone will differ depending on where that person is at, but they need to know that you want to see their child vaccinated. There's the link, there's the website, and I want to recognise all the partners involved in this work. Thank you.
Good morning, and thank you, Arnaud, and thank you, Julie, because you laid a very nice ground for me, because right now I'm going to tell you about the Romanian experience and how we try to use motivational interview to increase vaccination and improve interpersonal communication between healthcare workers and caregivers in the country. It's a long title, but then it's been a long process. A little bit about Romania. We are an Eastern European country, 19 million people. And in terms of health and immunization, we have a decentralized healthcare system, which means that more often than not, regions and local authorities have their own way of doing things. The GP or the family doctors perform routine vaccination, except of course for the vaccines done at birth in the maternity wards. Routine vaccination is not mandatory, and there is no systemic proactive approach to vaccination. There are also high migration rates within the EU, which means that a lot of children who are in the scripts of the family doctors may or may not be vaccinated, and sometimes people lose track of them. And the immunization rates are not optimal. The rates there are as 2019 when we started this project, but now they are a little bit lower. We are about at 75% with the second dose for MMR in 2021. In 2016, we had a measles outbreak with over 20,000 cases and to us a number of staggering 64 deaths, most of them unvaccinated children. And ever since 2016, in UNICEF, we tried to work with the authorities and with the caregivers to increase vaccination rates, to increase demand for vaccination, and to improve the way the system works. In the same way, in the context, a small research done by WHO in Romania showed something about the healthcare worker and caregiver relation. And the most important thing is that healthcare workers, and especially the GP, are still the most trusted source of information for the Romanian caregivers. Nonetheless, the way that the GPs communicate with the caregivers is still wanting, because almost a third of the caregivers did not know where to go to get information about vaccination. Half of them didn't know when the next vaccination was due. And also 1/3 said that they did not clear or they did not get at all information about the vaccination or about the side effects. And this is where everything started to get shape, because in the previous times, 2018, 2019, UNICEF globally developed and tested an IPC package for immunization, and our region took it and adapted for Eastern Europe. And at about the same time, we had this wonderful partnership with CDC, and we wanted to address this gap of information, gap of communication between the healthcare workers and the caregivers through this project. So we aimed at designing, implementing, and evaluating a motivational interviewing-based intervention to increase immunization uptake among children starting with 6 months. Primarily, of course, we wanted to increase the coverage, but the secondary objective was to increase the quality and effectiveness of interpersonal communication, basically to increase the trust between the caregivers and the healthcare workers. And we did so in 4 counties, and you see on the map the ones in darker colors, and then in the table, there were a set of criteria that we applied. Most of them refer to immunization rates and the similarities between the counties. And I'll tell you later on, we did this in 2 stages, and I'll tell you why. We started by a communication needs assessment, which led us to adapt the training curriculum and implement the training. And then the last stage is going on about now. We're evaluating the whole intervention. The communication needs assessment showed us something that we knew, anecdotally, and we knew from other researches. The healthcare workers report some instances of vaccine hesitancies among their own colleagues, and they also believed that the major causes of vaccine hesitancy among caregivers are out of their control. To be very honest, I mean, the phrase that we most hear from healthcare workers is, we did everything we could. They just don't listen. We gave them all the information, they don't pay attention, they are listening to the influencers, or they just don't want the children to be vaccinated. So there is a dissociation from the responsibility of the healthcare workers, and most often than not, the blame is on the caregiver. In the realm of the caregivers, there is a lack of perceived need for vaccines. This is, of course, the success of the previous vaccination campaigns, when the rates were very high and some diseases were eliminated or eradicated. And the caregivers view healthcare workers as a trusted source of information, but then again, they need more information. But when we ask them what information you need, they're not able to pinpoint this. So I think that what we realized is that they don't actually need more information. They need a different way that the communication, the information is communicated to them. And then, of course, the caregivers' hesitancy is also influenced by and disinformation. Romania is a country who's highly active on the internet, and the social media has a lot to say to them. And what we did was to take this into consideration while we developed the training. So the training that we applied in Romania is a very interesting mix for us, because it started on the IPC for immunization package that was already adapted for the Eastern European region. It was adapted to the local context based on the communication needs assessment. So we made sure that we have there chapters on, elevator pitch, chapters on addressing misinformation and disinformation, chapters on what type of information the caregivers need. We had a special, dedicated subchapter on the ever-going, I think this is something that will never disappear, that MMR vaccines cause autism. All these things that were relevant in this context. And of course, last but not least, but on the contrary, it was adapted around the motivational interviewing spirit and techniques. And this is where Arnaud's involvement was crucial, because he was there with us, at every step of development of the curriculum and in the trainers training. The principle was like this: we will have a TOT of 3 days, and then the training sessions for the healthcare workers for 2 days. The selection of the participants was based on their willingness to participate. There were no incentives from our side, except for the, paying for the accommodation and the transportation. it wasn't a rule, but a very strong recommendation is that they participate in pairs, the GP and the nurse, because they are a team, and whereas the GP is seen that the trustworthy source of information, he's also seen, like on a pedestal, he's, somebody with a higher authority, whereas the nurse is more like your peer. The nurse is talking to the mothers in a way that the mothers understand, and the emotional involvement of the nurses is sometimes a little bit higher. So we wanted both of them to be able to have the skills to communicate with parents, to complement each other. But we also welcomed other professionals, which was a very good thing, neonatologists, people at the maternity wards, community health nurses, and other healthcare workers involved in vaccination. So we had 2 stages, one in 2 counties, Brașov and Vrancea. These names mean nothing to you, but you should know that they are different in terms of urban versus rural, number of GPs versus number of community workers, and cultural backgrounds and number of children born. You saw that, and you'll see it in the presentation in the table before. We had 174 participants out of a target of 300. So when we realized that the pool is drained, we moved to 2 new counties with similar backgrounds. And here you'll see that we had 180 in 13 trainings. And that's a lot. Not only for the number of sessions, but it's a lot because in the end we managed to have nearly 400 people trained. I will go very briefly over this. There's a facilitator's manual, a participant's manual, and most important, and Julie showed something in her presentation, most important for us is that we developed a set of materials that are, handouts from GPs to parents, handouts with the most important facts, handouts where the GP can put their contacts to be available to the caregiver at any time for information, and also a set of important handouts for the doctors. It's like like a cheat sheet, something that they have available on their desk at any moment because they need to be reminded and they need to remember all the techniques and all the thing. If the caregiver says this, what do I do? So in order for them not to go back into their memories, they have this little things on their table. Well, that seemed easy, but it wasn't. I'll speak a little bit more about the challenges, the changes, the enablers, and the lessons that we had from this training. The challenges, the first and the most lovely one was the pandemic. It started right when we had the communication needs assessment, and we had to be very flexible about it because we started with focus group discussions and we ended up having some in-depth interviews online because we couldn't, move freely or have meetings anymore. And the COVID pandemic took away from us the focus of the healthcare workers because everyone was now involved in a response. The needs assessment I mentioned, the curriculum development, it put everything on hold. Every one of us was involved in something else. The training delivery, all the conditions changed for the training delivery. This was a training that was developed and designed for face-to-face. We tried an approach to have it online. We did it in another side project. It didn't work. We went back to delay the trainings, And it also had an impact on caregivers' hesitancy because at some point, and there was a presentation before that showed that COVID-19 had an impact on routine immunization as well. One other thing was that motivational interviewing was relatively unknown, and motivational interviewing for immunization was a total novelty. So from this perspective, we had the reluctance of the GPs to take on a new training on a new method. And this brings us to other two challenges. First of all, the communication style of the GPs and of the healthcare workers, which is, like one way, unidirectional, and very directive, and and they've been doing it for years. It was validated so many times for them. Why should they try something new? They had also a reluctance to training. This is a whole new discussion. I mean, it's a systemic thing. We have tons of trainings for GPs. Sometimes they just, open, if they have it online, they just open the session and they do their own thing, and they come back when the session is over, they click and they get a diploma or some points or something. It's, and for a training face-to-face, and for a training that's at this dimension, and which requires their attention and their involvement, they're quite reluctant to take it. And then for a later stage, but which is very important to us, is the need for official mechanisms to maintain change. Because first of all, we need to change the approach of the healthcare workers. This is what we did through this training. But through a 3-day or a 2-day training, you can't change very much. You can give them a basis, but this change needs to be maintained. And it takes time, and it takes money, and it takes resources to do this. But we also saw some changes. The pre and post-training tests show an increase of knowledge, and the observations that we had during the training sessions showed very nicely. I mean, this was the most rewarding part for us, that it showed how their attitude changed from reluctance to understanding, sometimes accepting, and for some of them even embracing it, when they admitted that it's something very useful for them, and they're not thinking necessarily in terms of how many people I can convince or to how many people I can talk. But one of their first complaints is, I don't have time for something new. I have so many people waiting. I only have 20 minutes to talk to them. I can't give them the information that they ask. I can't pay attention to all of them. But they understood that this is something that takes actually little time. You just need to switch, to twitch a little bit the way that you talk to them. And then there were observations during the supportive supervision that show how they continue, or at least part of them continue or try to keep this change, try to implement the changes. Because what we did, because we needed that one thing is not enough, we had a supportive supervision, a mentoring program that followed the trainings. It was also, it wasn't for anyone, for everybody, it was for the people who wanted to take part in it, but it was good because it created a community where they could exchange experiences and they could advise each other and they could actually remember the techniques that they learned. It couldn't be just all changes. There were some enablers as well. The peer-to-peer TOT, it was highlighted in green on another slide. That was a very good lesson for us because the first trainers, the trainers for the first stage, actually trained the trainers for the second stage. And it was, it's not the wheel, it's not hot water. It's probably there before, but it works. People are more open to receive the information from their peers, and the trainers, have their information and their skills validated, in this training of trainers, and that worked very well. And the new trainers, the ones in stage 2, went on to be very motivated when they started their trainings. No? And at the same time, there was something else that happened when the first TOT happened. It was that the information was taken from authors of the manuals or highly respected figures in the healthcare field in Romania. But there were still questions unanswered, and the trainers, had to find answers to these questions by themselves. But in turn, they were very much able to leave the new trainers with the entire information. There were so less questions there. The decline of the pandemic made things easier for us, and the participation in pairs, I spoke about it, it proved to be a very wise choice because these teams complete each other. Then the word of mouth, of course, happened, and it helped us a lot because, when the first people come, they're not very well convinced of what's happening, but when they realize that something good is, they brought in a lot of their colleagues. And, of course, the supportive supervision, but this was part of our intervention. This was like a part of the project, but it needs to be taken up by the system in order to make this change permanent. Well, the lessons, the first of all is be flexible. I mean, some of these lessons are redundant when you read them like this. You have to be flexible and able to adapt. Something will always happen. You have to be open, and we had a team of very open people, from the implementers to the partners in CTC. The second one is to bring on board as many stakeholders as possible. This is also something that's, it may look commonsensical, but if you bring in all the gatekeepers, all the influencers in the community, all the authorities who aren't even supposed to do anything, but if they are informed and kept on track with the evolution of everything, they might be able to help you and bring you open some doors, bring you some solutions to you. They know the people that you target. They know better than you to what they respond. And then there are two that are very important. We need to be persistent. I mean, from my perspective, the hard things happen from now on. I mean, the trainings are done. We have experience of these 300, nearly 400 people that are trained. But in order to mainstream a novelty like this, it takes a lot of time. And we need to persist to advocate with the authorities for this change to happen. And we're doing now the evaluation. First of all, it's the registry books that we are reading to see if anything changed in this period. And then there's a KAP study with caregivers and healthcare workers before the training and 12 months after the training. It's a control group and a treatment group, and the data is being collected right now, and I think that in December we'll have the final hard data and the final results. And thank you. This is something that we're going to do. I mean, not to leave things as they are. We plan to go further with, mainstreaming, motivational interviewing, and communication between healthcare workers and caregivers. And thank you. No. Yeah, that's right. No, there was something else there. There were here. This is it? Yeah. Oh. We had all the people, we had like 20 people from the CDC teams, from New York, from UNICEF regional office, everyone who was there involved in this project, yes. Oh, but I will go and thank them personally.
Thank you. Great. Thank you, Raluca. Thank you to the presenters so far. Hinda will be up next, but just a quick announcement that because this session started 15 minutes late, we'll go to 12:45. Please.
Hey, I am delighted to be here today and invited for this conference. I would like to share for a little bit of history about Somali community in Minnesota, especially city of Minneapolis. And also I would like to share for a pilot for intervention that we did for the community, the study. So first I will, the community, they have hesitance, but that hesitance is having history behind all of it. And I would like to share a little bit moments for that. Somali community in Minneapolis has was historically been targeted for misinformation. And this community, for this misinformation, they end up having a very, very low MMR vaccine. But they are not, they was not having this hesitance before, but this came from the fear of autism. This misinformation they share for that MMR, the children who's getting the MMR, they are developing for autism, which is autism spectrum disorder. In the community, we are Society of Oral, that they share, and also a couple of community, they get the diagnosis newly for autism, which they did not hear before. So that all fired the people to feel hesitance for the vaccine. And also there was a study that did University of Minnesota checking for the children that diagnosis for autism. So what happened is the community, they came that in 2010, when the research happened, the conclusion came 1 in 32 Somali kids, they get autism. And the first for comparing with the 1 in 36 for the white children. And then community, they said, we are minority here, we are not majority, and we are having this much. So each parent, they was like getting really alarmed. And the new mothers, always when they are pregnant, the first child, they like to ask the senior mother who was having the children and asking them more question about, I am getting child, what I should do it, what I should not do it. So the first thing that they all shared was do not give your child the MMR vaccine. So that it came sharing widely. And the vaccine of the community, from the beginning, they was one of the highest who vaccinated their children in MMR, and automatically came decline, and they ended up in 2018, the children, we have a system that measure for the children who born in Minnesota and get the vaccine updated. We have system that we loaded for the immunization uptake. So the numbers show year by year, the community was going down. So intervention that we start was going the community, knowing more about what is driving for this. And some parents, they honestly was sharing. Some they will say, I will not share now, but I would like to get some, after you finish the talk, we start talking about the basic of the immunization, and we start also doing more translating the information that was available to people know it more about it. But one thing that we came to know in 2017, we hosted Minnesota, they get outbreak, measles outbreak. And we start making intervention and education session for in-person radio, and also going faith area, school is many other areas that people are conquered. And when the people, they heard that vaccine rates went up within the first 2 weeks of the outbreak, we get children that we was having the rate 42, we reached 58% people was getting the vaccine. And we asked them, we were so curious, what make them to be able to get the vaccine. Many they were saying, measles is really contagious, and when we heard that, we vaccinated. Even some people, they was agreeing to give vaccine, child who was 7 months, even though it's still not reached, but because of explaining the way that measles are spreading, and the people always, they go some of the area that we socialize it, and to be getting more and more the people. So, but they're lucky that we ended up having 75 people who was exposure for the measles. And all was not Somali, also other community was included, because measles start first dose for 1 year to 1 year and 6 months. So the children who was infants also was high risky, and this is start from the childcare. And here is for MI in the peer-to-peer. Why peer-to-peer was important to empower and improve the information to use for providing patient interaction and interaction between the equals. Early development brought in the community members. The reason that came this is wherever the person he want to get the vaccine, they know that child, when he has autism, there will be some delay. So the first question they will ask is, my child will get some delay, my child will get the autism, because this is the way the anti-vaccine or the people who always share the misinformation, they was sharing it. And early development is, they are believing is watching the child not enough, but avoiding for the vaccine, maybe it will be the prevented. So we started for promoting about how they can early intervention, better for not wait, because before the people, they was hiding when they have child autism. But the early intervention is really improving for a child who has some late development for the birth, after the birth, or when child reached 2 years old. Consultation with the community members and intervention with the 10 parents is conducted by local trainer interviewer that we learn this MI. This was the course, that content that we did for this pilot, and how vaccine work. Like simply starting for the basic way that person, why he's getting vaccine, what vaccine will do for his body, and how it's protected. How we can know vaccine are safe. We know scientists was 100 years that, and it go process for safety, and also even if FDA approve it, still the vaccine will go for process of monitoring. Where we get the truthful information, the person what he can get is the fact information. It's not for the internet. Internet is a lot of information is there which is not right. So the person always to look at the Center of Disease Control of our Minnesota Department of Health. We have website that we have all the information available. Understanding where people are in their vaccine journey. I think the best way to know if the person, his journey or journey of the person where he is, the vaccine, just simply without saying, maybe you're not vaccinated, or blaming him, say, what do you know about the vaccine? And maybe he will tell where he is, that person. And then you can give the comfort, if he agree with you, that to give some information, or where he has the gap to share the person. How to have conversation about the vaccine. I think the best way that in personal experience is do not always share the person to say, I think you did not vaccinate and I will give you information. No. I am so-and-so and I have some information. If you need it, I will be available here every day or every other day or month once. So the person who has question always will be follow you wherever you are and will ask his needs or where he has the gap. Planning our conversation and how to talk with the vaccine supporters. I believe for vaccine supporters, they can be good or they can be bad if you did not give fact information that they can share. If they are not for the medical sectors and you said, oh, we are having gap for the immunization, but you did not arm them well, and then when they go, only they know that the community they have low, but they cannot answer all their questions, and maybe they will be making misinformation more than you was thinking it. So arming them is giving appropriate information that they can share, and also giving them direction that if you find someone who has questions that you cannot answer, everyone will not know everything, but you can direct them back to their provider. Is the best way to be returning back to patient to his doctor. And the doctor is the best person who can guide and give the comfort information. How to talk with the vaccine refuser. Person, if he's refusing something, that means something is behind his mind but to know it, it will take you time. It will not be enough for one day that you meet and you will argue. Arguing will not solve the refuser problem, but you need to learn it. There is open questions that you can ask a person, and he will share why he's refusing the vaccine. Sometimes it's a very, very, very simple. Maybe person don't have a card of insurance card, but in the government we have system that can help a person who don't have that. But what about if we live and he will be we will think that he refused and he don't like the vaccine, but always find it what the cause of this refuser and ask it, may I know it? May I know why you are refusing the vaccine today? Is there anything that I can help, or do you need any help? That maybe will bring back to the person in the right direction, and maybe he will tell, I don't have insurance, or maybe I have, maybe other doctor, he is the one who advised to not get enough the vaccine because maybe child is taking some cortisone medication, which we know that if the person is some of the medication, he has to wait until he will be bust for the time that he can get, and vaccine will work if he get for his antibody. How to talk with the person who is vaccine hesitant. The vaccine hesitant is a person who is not sure, or person who's feeling like he don't have all the information that he needed. So that person, it will look, if anti-vaccine is the person who gives the first feed, then the truth cannot catch the lie. So it's not needed that person to be like hardship talk. You will just give some information. If you need more information, I will be happy to help you, or I will be happy to share what I know, and what I don't know, I will direct you where you can get the information. Here is the video that we call Novella Learning, and this video is started during the COVID pandemic, and it starts for method that family loss and motherhood and grandhood, while taking others about the COVID vaccine around immunization, and also routine immunization law, or immunization that comforts. This method was working well and was shared the people who was having lost it. And just we are sharing this. And also communication and skill. Communication is the biggest door that if you communicate well, you will reach a good goal. But if your communication is not clear and is not trusted, built way, that will end up the road that is not going well. So this is showing a person who was having vaccine concern, and he get the information well, and that information directed to change his previous, what he chosen to not vaccinate. He started getting the vaccine, and also during the COVID, there was a lot of immunization against of the immunization that they were saying COVID vaccine start fast, and it did not go through all the things that was needed. So communication, it's open in the way that person can get the information that he needed. Pilot round 1, there was module that for modeling, delivering for SMS or WhatsApp. But this role did not work well. The reason is people were reluctant to give their phone number. But the other hand, the people who was started the course did finish it. And this was for person who stay in his home can do this course through his phone number. And he was just using the app, and app was translated English and Somali language. The pilot round 2 was an initial Zoom training in December 2021 to test for a new format and piloted for videos and to examine feasibility Zoom training with the local public health. And that the local public health that who was attended was 33 person, and they was in multiple ethnicity group. And also there was other group that they did in the Somali community, and total people that was training was 12. And that 12 was leaders, parents, and that in the app, pilot lesson learning, what we know and what come out for that. In-person training, preferably to SMS or participant, and they was really like that, and they learned. Participants requested slides in English, and slides they request English, but they also requested for the video as a Somali language. So here it was the one gap that the written translation into slide of Somali was not accurate due to the person who was translating some of the terminology was not correct. So that is the reason people they were saying they choosing to get English and then the first for the Somali. The feasibility for peer and best training, best testing indicated that participants understand like outcome of the pilot feasibility was improving on the sitting conversation goal and how to build the trust. And now I would like to introduce Dr. Nessa, and she will also tell for the field of the test in Kenya. Thank you.
Thank you, Hinda, and thank you to our previous presenters. So I'm going to share about the field test that was really informed by the work that was done by Hinda and colleagues to develop the peer-to-peer modules. And just to, I don't know where I'm pointing, to go back, just to reiterate the important bits about the course content. So it starts with how vaccines work, how you can tell they're safe, and as you move through these lessons successfully, you're presented with the examples from COVID-19, but then as you move towards the second half of the content, it's really focusing on routine immunization. So it's important to note that the individuals that are the target for this type of training are themselves would be categorized as vaccine supporters, but we teach them how to first identify someone as being hesitant towards vaccination, being supportive of vaccination, or being refusing vaccination. And that's how you kind of figure out understanding where people are in their vaccine journey, because you're going to tailor your conversation based off of that. So we built on the pilot that was done in Minnesota, and we planned for and implemented a field test in Kenya with partners. So we used a mixed methods approach, which means that we collected quantitative and qualitative data and then triangulated to see if findings were supporting each other. So our aim, first off, was to assess knowledge and perceptions about how do people usually talk to peers about COVID-19 vaccine and routine immunization in this context, right? We had an understanding of feasibility in the Minnesota population, but that doesn't necessarily mean that this is going to translate into the Somali diaspora population in Kenya. So we really wanted to understand, would it be feasible, acceptable, and usable in this context? And importantly, we also wanted to hear from these potential users around what they might suggest as adaptations to make the tool more appropriate for this setting and for the needs of this population. So we thought it was important to talk to caregivers, those who were identified as community influencers, and also health workers, which included clinicians as well as community health workers and volunteers. And so we carried out these multiple sessions, and within a session, we would begin with a pre-questionnaire to get the baseline understanding of knowledge and perceptions. The group would be introduced to these e-learning modules. So whereas, as Hinda, you'll remember, mentioned, they preferred in-person and Zoom to the SMS text messaging. So these modules can be delivered via text, but learning from our feasibility test, we wanted to deliver them in a group setting, so they viewed them on a laptop. And there, as you remember, there was 10 modules altogether. It wasn't feasible to deliver all in one setting, so each group would have about 3 to 4 that they would view together, but across the entire sample, all modules were seen, but not each model was seen by each individual. So then after they've had that group setting viewing, we then individually assessed changes in knowledge and perceptions through administering the questionnaire again. And then we would engage as a group in focus group in discussions around how feasible, acceptable, or usable did they find the tools and what potential adaptations they would suggest. So what did we find? Well, in a nutshell, it seems like in this context, the video modules were feasible, and we know this because from our quantitative, we saw a statistically significant increase from the pre to the post measure in knowledge regarding motivational interviewing techniques, as well as how to engage in peer-to-peer vaccine conversations, as well as an improvement in vaccine perceptions. So we saw that there was a 13% increase in the proportion who responded correctly to the questions that we asked around motivational interviewing techniques and engaging in vaccine conversations with peers, and there was an 18% increase in the proportion who perceived that COVID-19 vaccine was important. And this, you don't have to read the full illustrative quote, but it's just showing how they're showing their knowledge around, how vaccines work in the bolded text, and then here it shows, how their motivations have changed. They've been taught how to deal with hesitant people and how to tell them your thoughts without offending them, and that's coming from a health worker. Also, we think they're feasible because intentions improved, and so we saw from the quantitative there was a 25% increase in the proportion who intended to get vaccinated for COVID-19, an 11% increase in the proportion who are likely to start a vaccine conversation with a peer after the training, and a 9% decrease among those who perceived that it would be difficult to engage a peer in this type of conversation. So now here we're hearing that they feel more confident. They've felt like they've had a mind change, and that, regarding their intentions, they've removed the fear from my heart and they're intending to get vaccinated. We also believe that the modules are acceptable and usable in this context, and that's because we heard reports, they find them, interesting and useful. They felt that the format for introducing this story, this novella format that Hinda mentioned, takes you through this narrative of a family, as they seek information from their imam. And as the conversations happen, you receive text boxes that reiterate the motivational interviewing skills, and they found that was that's what they're referring to as the breakdown of information. They found the videos relatable, and they felt an emotional response to them. Regarding usability, the respondents did say they felt comfortable watching in a group setting and on the computer screen, and they thought that the duration of time was appropriate. So in regards to what we're planning to move this work forward, we would like to implement and scale up the full set of modules. So we're going to implement the adaptations that were proposed by our community members. We'll continue to engage stakeholders. I think that's something that all the presenters have reiterated is an important part of doing this type of work. We'd like to, as I said, implement the full modules and then also follow up over a longer period of time, still maintaining that rigorous evaluation that brings in the quantitative and the qualitative understanding and disseminate broadly. If anyone is interested in viewing the modules and potentially using them in their own work, they're available at this QR code. Also, I didn't mention it, but I showed it when we did the overview of the session. That included a QR code that had a link to the role-playing exercise that we're about to engage in, so you can have that pulled up on your phone. We'll go back to it when we get to that point. But I'm going to actually propose that we skip the Q&A and just move directly into the role-play. Okay, and here, a big thank you to all the people that are involved in this work. I think we've all seen that our work is all highly collaborative, and it takes a lot of effort from a lot of individuals representing many organizations. So we're going to play a small video before we start our really fun and engaging role play exercise, and we're going to pass around a checklist that you guys can use to write on, but also please take it as a resource, and as you start to engage in using these MI techniques, you can reference it. But Julie was kind enough to share. Would you like to introduce this? Okay, this is an example from Julie's work. We're going to provide you first an example of what not to do. So this is like a not good version, and then that will be followed by further elaboration from Arnaud's work on the video that we watched in the beginning on how to engage in these type of skills. So this is a very brief video, and away we go.
Yeah, look out. How you going? Sorry I'm late. I just come back from having my flu shot.
I'm not having one of them flu shots again.
Why?
My mum had a flu shot and got the flu.
Yeah, but the vaccines don't give you the flu. It's probably just another virus.
Nah, it was right after she had that shot. She crashed right after it and was in bed for days.
That's more like another illness, I reckon. Flu shots can't make you that sick. There's a lot of myths and misinformation going around on the internet.
Look, I'm not anti-vaccine.
Nah, look, there's a lot of news out there, a lot of misinformation. On Facebook, you see all sorts of rubbish.
Nah, I'm not even on Facebook though, but I'm just telling you, Mum got real crook.
Yeah, look, I know your mum felt sick, but her getting a reaction from the flu shot doesn't mean you're going to feel unwell if you get it too. You'll be right, sis.
Yeah, well, you can't be too sure with all the new things they put in these vaccines and what they do to the body. And there's no long-term safety studies been done yet either.
Yeah, but they've done lots of studies to make sure the vaccine is safe. I think you've just got to ask yourself, if you got the flu, how much would you regret that you didn't get the vaccine? Or if you pass it on to your other mob, you put yourself and others at risk.
Look, sorry, I've got to go. I've got to go and pick these kids up from school.
All right, well, I'll talk to you later, all right?
Okay, yellow.
So just to explain, that was used in a training session, and then we co-wrote a script for a positive communication exercise where we gave people little cards where they highlighted when they saw a good practice in the role play, and it was bingo, so when they crossed off all the practices they could yell out bingo and get a prize. So we did that script writing collaboratively with those Aboriginal health workers that you just saw, Christy and Kylie, who are happy to take, further acting work, they said to say to you. So, Nessa, you introduced the role play? Yeah?
Great. Okay, so we'll be working in small groups. So I think you can organize yourselves. You can actually work with just a group of 3 for this, because 2 people will be the active people in the role play and 1 person will be observing them and, evaluating them as they go. So you'll start by assigning who will be doing each of those 3 roles. And if you have a group larger than 3, then you would just have additional observers who would take some notes during the interaction. So there's 2 scenarios that we're presenting because our work, we work the motivational interviewing interventions that you've heard about this morning. Some are working between interactions between healthcare workers and clients, and some are from peer to peer. So we have 2 examples there, and also one is focused on COVID-19 and one is focused on RI. So align, when you get into your groups, you can decide about which one seems like a better fit for you, which you're most interested in, and then using the scenarios, which will be presented here in a moment, you'll apply the MI techniques that you've reviewed. And we've passed around this sheet, which, think of this as like a checklist or a cheat sheet, where it has 5 of the MI techniques in the first column, the objective mapped onto each of those techniques, and then some examples of what you might say as part of that, the rhetoric, and then a do's and don'ts checklist. So for example, open-ended, do use open questions to further clarify their questions and concerns. That's an important step. And the converse of that would be don't ask leading questions. And so the 2 actors can use this section to help guide their interactions, and then the observer can use the last column to kind of evaluate the quality of what you're hearing. And then, so I think we might need to adapt because we're getting close on time. So maybe we'll provide feedback as a group instead of individually. So we'll spend most of the time doing the actual practice interaction, and then we'll come back as a group. So we'll give them 5-6 minutes to try this. Okay, great. So we won't explain this, but you'll be able to read it. And then here are the scenarios. So the peer-to-peer, this is from one caregiver to another. So you're a new mother living in rural Thailand. Your cousin invited you to lunch. You're not sure what she intends to talk about. But regarding the COVID-19 vaccine, you feel like you really don't know much about it. You're not so interested in it. You've been exposed to some information online regarding it. You also don't want to embarrass yourself, but you are going to play up some of the myths and misinformation that you've heard. But you're going to listen to what your cousins say and see if it changes or doesn't change your mind. Then the role of the caregiver who is supportive of vaccination, you've asked your cousin, you've invited them to meet because you're wanting to talk about their COVID-19 vaccination status and encourage them to get vaccinated. So that's scenario 1. So if you're interested in trying the peer-to-peer approach, this is the way to go. If you're interested in the healthcare worker and client one, so role 1 would be the community health worker. So you're working in rural Thailand and you have a caregiver coming into the clinic and you're going to practice the MI techniques in that interaction. And then as the client coming in, you don't know much about the services offered generally or about routine immunization specifically, and you're not sure that you want to get your children vaccinated. So again, you're listening to what the community health worker presents, and you may or may not change your mind based off of what you're hearing. And we won't do this, so we'll skip that. Okay, so if we can go back all the way to the intro slide. Look at all that we learned and covered. There will be a QR code where you can pull up the scenarios to read, so I'm just going to give that to you. And then we'll leave the scenarios up on the page, up on this larger screen too, so you can read through them. Does anyone raise your hand if you think you might be interested in the peer-to-peer scenario? Raise your hand if you might be interested in the healthcare worker scenario. Okay, so we'll just do that one because everyone seems interested in that. We're going the other way again. And we're happy to share resources or slides after the presentations. Does anyone have any questions about what they're reading on the form? And we can be very informal in this setting. So we'll circulate, we'll walk around, and if you have questions, you can ask us one-on-one, but it's really just a chance to get to practice.
It's gone too far.
Oh, no, we'll leave the scenario up, will we?
Right.
Yeah.
I thought you were going for the QR code.
Oh, okay. Great. So I think it's this one that people indicated, the healthcare worker to client. Yeah. So feel free to join into groups of 3 to 5. We're a smaller group now, so maybe a group here in the front, a group towards the back, and maybe 2, 3 groups over on this side. And again, you're indicating who wants to be the community health worker, who wants to be the client, and who wants to be the observer.
So do you want us all to circulate, Nessa? Do you want us all to circulate? Yeah? Come on. We're observing. So Nessa's just suggesting that we...
I know this is fast, but 1 minute warning and then we'll come back together. So try to finish up your conversations, come to a close. Okay, can we come back together as a group? It might have been that you were just getting to the good bit, but... Mm-hmm. Oh, they're debriefing? Okay, great. Yeah. So the observers can go ahead and debrief to the actors. Tell them, something that they did well, something where they may have missed an opportunity to use a technique. Okay, so we're at time, we're over time, but if your conversation is still going, please feel free to stay on and continue, but we're going to officially end the session and just say thank you for coming and attending and participating, and we're available for any questions afterwards, but thank you, and I'll place our contact information here if you'd like to reach out after the session.